All right. Well, thank you very much. It's an honor to speak at this meeting, and it's our eighth meeting, and definitely one of the best meetings for residents and fellows in the country. So these are my disclosures, and so just in talking about deformities, I just wanted to remind us of the fact that this Glassman article from 2005 is what really established deformity corrections as a desirable thing to do in the sagittal plane due to our ability for the first time to make a correlation between radiographic measures of deformity and patient-based outcome measures. So very important to read that article and acknowledge it. So this is just some further information focusing on the sagittal plane as opposed to the coronal plane. And so, what's the overall clinical presentation of degenerative scoliosis? It's not the same as idiopathic scoliosis because it's an older population. You frequently have radicular symptoms due to facet disease and facet hypertrophy with resultant leg pain. In addition, you also have back pain, and there's fatigued muscles due to compensation for the deformity. And there is the risk of progression of the deformity in the degenerative population of scoliosis patients, whereas with idiopathic scoliosis patients, the risk of deformity progression is not as accentuated. So these are the radiographic features of deformity, the curve stiffness, degeneration of the disc. You got to contemplate the degree of osteoporosis, how much sagittal imbalance is there, whether or not there's rotatory subluxation, olisthesis. All of these are factors that we need to assess from the plane films in conjunction with other radiographic tools such as the MRI or CT myelogram. There are a variety of indications for surgery, and we've discussed all of these, and there's like Dr. Okonkwo said earlier, there's an art to this. You can choose when to pull the trigger based on what you think is appropriate. And every patient has a different story, and every surgeon has different experiences that influences how he or she manages things. And so it's important to develop your own paradigm for offering surgery. The importance of plain X-rays and deformity cannot be underestimated because it's very revealing of where a patient is in real life as these films are done with the patient standing. But in addition, you can have dynamic studies which show to what degree the patient has a dynamic process where correction can be achieved simply by positioning or bending. So very important to evaluate that. And if you don't have that, but you do have plain X-rays, it's important to remember that most CT scans are when the patient's laying down, so you do have some degree of an ability to assess how much the patient will move just based on looking at the sagittal alignment of a CT scan because they're laying down on a CT scan. So, but ideally you should have standing films, laying down films, bending films. All of these are important ways to assess what you need to do in the operating room. So basically, as we discussed, bending films play a big role, especially in the scoliosis population, and even more so in the adolescent idiopathic population because it's the inherent flexibility that the younger patients have that will help you utilize hardware and instrumentation to get the deformity as opposed to osteotomies. So we all are familiar with these radiographic drivers of disability and our overall surgical goals. We want to get the pelvic incidence to be as close to the lumbar lordosis as possible, and we want the sagittal vertebral axis to be approximately less than 5 centimeters. and we have to take into account the degree to which the patient is tilting their pelvis. So we have to look at each one of these parameters and plan our surgeries carefully. So, what are the treatment options for surgery? The gold standard and the most common way is standard open surgery, and this is what I most commonly do. But there are other techniques as we learn more and more about them. The minimally invasive approaches, such as the transpsoas or oblique lateral approach or hybrid procedures. We're still trying to figure out which approaches are the most ideal, and it really depends on the individual clinical scenario that you're facing. So patient selection and surgical selection need to sort of be blended together to figure out what is the optimal surgical strategy to treat these patients. And very often these deformity patients have multiple comorbidities, and if there are multiple comorbidities, you need to plan a surgical strategy that is going to allow that patient to tolerate the procedure. So we'll go through these in patient cases. So what I'm going to do is present a few cases, and some of these are going to be open deformity cases. Some of these are going to be minimally invasive cases, and we're going to talk about each individual case and each individual patient's characteristics and why I chose one procedure versus the other. So we'll start out with this one case. This is a 51-year-old with a progressive worsening of kyphoscoliosis. She had had a previous two-stage anterior-posterior correction of her kyphoscoliosis, but she had worsening pain and worsening spinal alignment. So as you can see, this patient has a multitude of laminar hooks combined with pedicle screws, and has had a previous anterior instrumentation for the treatment of her idiopathic curve. And so it's a bit of a dilemma as to how do you go about treating this deformity. Clearly she is getting progressively worse and is very unhappy. So what do you guys think? What's the most appropriate first step in this?
Did Kojo do the surgery?
So and if you need a CT scan, the CT scan shows that this is a solid fusion.
So Charlie, there's the names up there. You can check them.
Are the names up here? No, I don't see the names. Oh, it is.
Kojo, I think, took off of it.
Okay. How
We're going
about
to present his cases.
Grant from Texas? So what do you think's the first step in someone with this problem? Solid fusion. And let's just say she has a pelvic incidence of 50 and a lumbar lordosis of 10. Right. So first step is you have to remove that anterior instrumentation in order to achieve the ability to get a correction. So I contemplated maybe we could just go in and cut the rod somewhere, but we decided to do an open approach and take out the hardware, and we succeeded. So you can see that's after the removal of the hardware. So now it's back to a standard kind of deformity case. Okay, so lumbar lordosis was 10, pelvic incidence was 50, pelvic tilt was 20. Now what? How about Mingua Li? No? How about Ratnesh Mehra?
I think that despite the fact that the lumbar spine is solidly fused, it obviously is lacking in the lordosis and maybe even has some kyphosis at the top. I think it's hard to tell, but it doesn't look like they did anything necessarily at 5-1, so maybe start with a 5-1 ALIF to see how much lordosis you can get out of that.
Okay, she has a solid fusion at 5-1. If the posterior elements are all solidly fused. Yeah. Okay.
You may have to break that solid fusion. So.
Right. Yeah. So basically, you need a substantial amount of correction. So, whether you do multiple Smith-Peterson osteotomies and multiple interbody fusions, or whether you do a PSO plus a couple posterior column osteotomies, it's becomes the standard, deformity decision-making process where what do you do to achieve the degrees of correction. So what we ended up doing was a staged procedure where we put in hardware and we did a posterior element resection. There was a severe leakage of spinal fluid with resultant blood loss of over 2 liters. So at that point, we decided that we shouldn't proceed with the PSO at that point in time, and we had her resuscitated and ended up completing the PSO and ended up with this construct. And this is her 3 years out, stable, content, and feeling much better.
You did one PSO at what level?
So this was a L1 extended PSO, higher up than I probably would do today. In retrospect, I probably would have had a more harmonious correction if I did the PSO further down, but I was trying to choose an area where there was minimal scar tissue, where the planes, the dural planes were fresh.
Can you just comment to everyone how, when you ever have a construct like this with all of these hooks in place, and now you're going to put screws into the thoracic spine, and you don't have the landmarks, so that's obviously much more challenging because it's just bone fusion mass everywhere. What other pearls would you advise for them, since we spent all this weekend talking about landmarks, to decide where to put the thoracic screws after a case like this?
Yeah, it's a good point. So if you look at the final construct, we continue to take advantage of the hooks that were there. So those were very solid fixation points with good cortical bone, and so we took advantage of them. But without those landmarks, then you basically treat it like an MIS case, where you get your AP view, look at the pedicles, and really imagine that you can look at the spine, but because it's an open case, but you treat it like an MIS case. So that's a strategy that I use if I don't have good landmarks. And we do have a BrainLab Arrow, which is a navigation intra-op CT. I don't really use it, but hopefully in due time we're getting this table that's going to make it more spine friendly. Right now, it's mostly for my cranial colleagues, but that would be the other, tool to use other than standard fluoro.
Last question I have, what do you think the instance is of patients having chronic SI joint pain since you instrumented to the ilium, but you didn't fuse the SI joint, which we know, and you have to go back and take the screws out of the ilium, and if so, what is the instance?
It's a good question, and actually, in a area of interest of mine. I've been putting in SI joint screws for the last year and a half or so, and it's I would say it's maybe about in 25% of my patients in whom I do a T10 to pelvis or T2 to pelvis, there's significant SI joint mediated pain, and the standard protocol for me would be to take out the iliac screw and see if that improves their condition. Very often it does improve, but very often after it improves, it gets worse. And then at that setting, I go ahead and put in SI joint iliosacral screws. So I've also skipped the removal of the iliac screw, and I've put SI joint screws in above and below the iliac screw from the side, and because I feel that the iliac screw provides extra stability and will help make the SI joint screws have less stress on them. So I've done both, where I remove the iliac screw and put in SI joint screws, or preserve the iliac screw and also put in SI joint screws. And so I'm still collecting data on those patients and trying to see what their outcomes are like.
Could you amplify on that? When you say you're putting in SI joint screws, what are you talking about? Something laterally across the SI joint?
Right. So I don't know if you're familiar with the SI lock system from Globus, but it's a lateral trajectory similar to the SI bone trajectory. So they're iliosacral screws. Yeah. So that's what I've been using.
So you put those in percutaneously at the time of your deformity correction, is that right?
No, this is after. This is maybe like 2 years after a T10 to pelvis, and they have, pain that.
Just a question: do you do like a block or anything to test first, or do you?
Correct. So all patients who get SI joint fusions, I have them pass through a series of conservative steps, such as a block of the SI joint. We also attempt SI joint rhizotomies with their pain management doctor. And if those things fail, then, we can move on to the minimally invasive stabilization.
25% pain, is that with standard iliac or S2AI? Is there a difference?
So I'd say probably the vast majority of all of the pelvic fixations that I do are just standard iliac screws. Only recently, within the last year, have I been doing S2AI screws. So I have the feeling that the patients in whom I've done the S2AI screws are no different than the iliac screws. So, but we'll see.
Last question, was this patient fused to the sacrum or to L5? I forget.
So this patient was fused to the sacrum.
Before. So if they're fused to the sacrum and you have the solid fusion of 2, 3, 4, 5 to sacrum, then do you always need to still put iliac wing screws in like you do on a primary case? Because you have so many points of fixation already, and it's a solid, massive bone. So what do we gain by throwing in iliac screws compared to the patient that's not had all of that stable foundation?
So my thought process on that is stress at the SI joint. So if you put in iliac screws, then it's conceivable that there's going to be less stress on the SI joint. And if you put in iliac screws, you're less likely to get a sacral fracture. You know, with all of the stress that's being imposed from T2 to S1, I think there's a fairly, I'm not sure what the risk is, but there would be possible risk of getting a pretty substantial fracture at S1 or below S1.
If I can weigh in, I mean, I agree completely with that, and I have had the painful experience of stopping with just S1 screws under a big deformity. I think the two arguments, number one is avoiding a U-type or H-type lumbosacral dissociation fracture, which I've seen in one of my own patients and in at least 2 or 3 that were done elsewhere. And the second thing is that it gives you typically an ability to, if you're working to get lordosis, having those pelvic screws in at the base, I think really helps, and that's really the fulcrum for the correction or the lever for the correction. So I like it for that reason as well. And I've gone to, and I've tried doing it with just one screw, in fact, in some of those cases as well, and I'm back to using bilateral screws. I just think I have a better construct and better durability.
I agree. I think that if you ever get one of those sacral fractures, and I've seen them, once they fall into kyphosis sacral fracture, now the sagittal alignment's completely off, and it's so hard to treat. I mean,
Very
it's
true.
a really devastating problem. They get the sacral fracture, they collapse 10 or 15 degrees between S1 and S2 for an insufficiency, and now you have a total out of alignment of the sagittal, and everything you corrected is gone, and it's just really a challenge. So I think it's much better to prevent.
Yeah, that translation, that anterior translation of S1 on S2 is almost impossible to cure. So moving on to this case, this is a 63-year-old healthy female with worsening of degenerative scoliosis, severe stenosis. She has about a positive sagittal balance of 10 centimeters and has moderate back pain. The most important part about this patient was that she had very severe stenosis, and so severe that a indirect decompression through a lateral approach, I thought, would not be feasible at treating her symptoms. So for this reason, we ended up doing a standard T10 to pelvis. And so this is a fairly standard case. And with so far, this woman is 5 years out from surgery, doing well, no trouble.
So Charlie, just real quick, I think Bob's going to talk about PJK somewhat, but do you think, these are the cases that are always like, they look great at three months, and then over the next year, you kind of, and every time they come to clinic, you dread looking at the x-ray because they're going to be a little bit more tilted forward.
This is 5 years out.
Oh, really? Wow. Okay.
Yeah.
Wow.
So she has not developed PJK, even though it looks like she's going to.
Remember, Ron,
So-
I think that
So, because if you look at her curve, like that's what she looked like pre-op, and she's living at that, so she's doing okay.
We have a high incidence of PJK here, Swedish.
All right, so this is a 55-year-old female, no previous surgery, but substantial worsening back pain and leg pain. And so again, this woman had if I remember correctly, there we go. Here's the measurements: 25 degrees of lordosis, 60 degrees of pelvic incidence. So how much of a correction do we need? So based on these measurements, we need around 35 degrees. But this woman does move. She's not like this. She's not fixed at this position. So a measurement of the CT scan shows that her lordosis actually goes from 25 to 35, and so she does have some flexibility to her curve, as evidenced by the gas and the disc spaces as well. That's whenever you see gas in the disc space, you can always get an appreciation for the fact that this is a fairly flexible deformity. So, do we need to do a lateral approach in this? Seeing the gas in the disc space, is that you'd think that that might be an option? I contemplated it, but I was worried about that lateral translation and the stenosis. She had severe stenosis there, and I was wondering whether or not she would get an adequate decompression through the distraction from the transpsoas technique. So I erred on the side of doing a posterior approach.
I agree that, every time everyone's worried that the exact decompression. That's why I think that stage protocol works really so well. Only if you do it, you're going to convince yourself what happens. So if you stage and you do it, you get them up and walking, you're going to be surprised how much decompression they get. I was as reluctant as you'd ever believe it. You just have to do it to see it. The only way you're going to know stage it. There's no other way. You do it, you stage it, let them get up and walk, and you'll be surprised. It goes. You won't take an MRI again. You'll be surprised how much the MRI does not change. We talked about that.
Yeah.
A little change in the MRI, but your pain's gone. And there's no other way you're going to ever get convinced.
Yeah, no, I think that I have some cases later on that I'm going to show, but this patient had pretty substantial stenosis at the level of the olesthesis, and so yeah, you're right. I could have tried it and see what would happen, but anyhow, in this case, I chose to do T-lifts and posterior column osteotomies, and so wanted to get a release at those in the disc space, and so these are expandable cages that were put in, sequentially. So there's a improved coronal alignment, and you can see there's an improved sagittal alignment, and she is doing very well and is content and happy. This just happens to be the iliac fixation that I used with a double-headed head to line up with the construct, and allowed for ease of double rodding at the bottom. Go ahead.
So your main reason for using a two-level T-lift there as opposed to a PSO was because of the gas in the disc space and knowing that it was a flexible curve?
Yeah, it was, sometimes I decide about whether or not to do a PSO intraoperatively based on how flexible things seem to be. But when I see that there's gas in the disc space, I usually am fairly confident that I can distract the disc space and get a reasonable correction and loosen it. So that's a comparison before and after. So again, showing that she did indeed have some reasonable flexibility to her spine, and showing the cages and the sagittal improvement. So this is a complex case of a patient. Actually, this case discusses that issue that we were discussing earlier. She had this long segment construct, and at one point in time developed a pseudoarthrosis at L23, and the referring surgeon did an L23 XLIF, and had removed the hardware distal to that because she had a solid fusion. But as you can see, she developed this bad sacral fracture, and so she had urinary incontinence and had profound positive sagittal balance. So this was another patient in whom I did a PSO, and as you can see, she ended up getting a improvement in her overall lordosis, and the sacral fracture several years after follow-up healed completely, and she's doing well. So just a depiction of pre-op and post-op. showing the improvement in her alignment. And 2 years out, still no issues. So what about, our lateral approach, and what are circumstances in which, that might be something that, at least for my practice, is mostly open spinal deformity, but, I still contemplate doing lateral approaches. So I'm, there's certain situations that are advantageous, such as a patient with severe posterior scar, patients at whom you are worried about a high risk of comorbidities due to excessive blood loss. So there always are a variety of reasons why you might want to err on something that is going to result in less blood loss, such as an older patient. So you can achieve good coronal correction in the absence of anterior column release. This is Juan's paper. What if you need a greater amount of correction? Anterior release provides you with that opportunity to get a substantial correction just by doing a one-level ALL release. So another one of Juan's papers showing the success of restoration of sagittal alignment when you do an ALL release. One of the concepts that I like to think about is what's the safest way to do an ALL release, and I think the oblique corridor may potentially be a safer way to access the ALL rather than through the trans-psoas approach, because you're closer to the ALL in this oblique corridor when doing the OLIF procedure. So again, that oblique trajectory, you dock it right at that on the left side, anterior to the psoas, closer to the ALL, and it gives you a better opportunity to access that. So this is a 52-year-old physician who has done some reading on different approaches and comes into the office requesting a trans-psoas approach. I thought she'd be a good candidate for it. She didn't have a severe, discrepancy between her lumbar lordosis and her pelvic incidence, yet she did have enough findings to warrant surgery, especially with those collapsed disc spaces and the scoliosis with the severity of the back pain that she was experiencing. So I thought she was an appropriate candidate for trans-psoas with percutaneous screws, and did well. She's 3 years out and is doing just fine. This is a 71-year-old with severe difficulty walking, a previous history of a cerebrovascular accident from which he has recovered mostly, but he still had a slight weakness on his left side as a result of the stroke. Somebody that I initially saw and was contemplating a larger fusion, but also seeing that he looked fairly fragile, I didn't want to subject him to a T2 to pelvis. So this patient, I was trying to come up with ways to do something smaller. He had some foraminal stenosis, but it wasn't horrific. So this patient, I thought, was a good candidate for a MIS percutaneous procedure. So he had OLIFs from the oblique trajectory with perc screws posteriorly, and these are his before-after shots showing the dramatic coronal improvement. One thing I had to do prior to this surgery is I had to do a 2-level ACDF because he had very severe cervical stenosis, and I always worry about the patient's neck during these oblique surgeries, because the head is sort of hanging there a little bit, not as controlled as you would like it to be. So I had to do an ACDF prior to that, and that's his sagittal correction. I showed these films to Dr. Anand yesterday, and the comment was made that we probably could have even improved the situation further if we did a 5-1 ALIF, and I agree. But with his history of being 71 and having this previous stroke, I just wanted to get him on and off the table as quickly as possible. So he's doing very well. So again, another patient with severe, profound sagittal imbalance with significant weakness and pain. My plan was to do a minimally invasive type of procedure to try to minimize his blood loss, and so that's what we pursued. We were able to do a partial correction of his deformity, and I attempted to get a trajectory into the L3-4 disc space. This patient was actually fused from 4 to 1 spontaneously, and L3-4, 2-3, and 1-2 were the areas that I attempted to do through the lateral approach. We achieved 1-2 and 2-3, but 3-4, there was too much activity from the EMG, so we aborted the 3-4 and just did a TLIF posteriorly, and much better than he was pre-op. He's 74. He still has sagittal imbalance, and so this gentleman is only 6 months out, so we'll see what happens to him. I left the rods long on purpose. So that's him. Coronally, you can see he's actually perfectly lined up. His coronal plane looks great. Sagittal plane significantly improved. So again, just a quick article to show that the foraminal decompression is significant. You can get a foraminal height or a foraminal area increase of 35% with the indirect decompression. But important to remember that your indirect decompression is only going to be substantial and is only going to be long-term when you've had a fusion. If you develop subsidence, then you're going to lose your foraminal height improvement. And so what are ways to reduce your risk of subsidence? Careful attention to release the contralateral disc when you're doing your disc dissection, and not oversizing your interbody grafts, and using a wider cage. All of these are measures that are going to help reduce the chance of getting a subsidence. So it's just a study from Pimenta showing that when he used the 22 millimeter cages instead of the 18 millimeter cages from the AP diameter, that the subsidence rate was smaller with the larger grafts. So that's all I've got. I just wanted to present a few cases, and certain ones where I thought open was better, certain ones where I thought minimally invasive was better, and